So I'm going to round this off. It's a tough act to follow after all these stalwarts that are there. And I'm going to talk about targeted biopsy in uveitis. So the biopsy in uveitis can be of various types. The overview is like this. I have quite a big, I'd say, presentation. I'll not cover all things. I'll need the biopsy could be targeted extraocular, which is systemic. It could be local extraocular, which could be conjunctival. It could be aqueous or AC tap, vitreous biopsy, subretinal biopsy, choreo-retinal, or it could be enucleation. And I'm not talking about your retinoblastomas and melanomas. If time permits, we might come to that. So we can click and go to some of these, but let's see, what time we have. So targeted extraocular biopsy. So typically, without too much of ado, if you suspect clinically tubercular or sarcoidosis, because both these entities require different treatments and long-term therapy, then since you can have abdominal issues as well, but the thing is that you get a good quality CT scan of the chest done, and then based on that, you can, for confirmatory diagnosis and not possible or probable, that's a mouthful, EBUS TBNA, which is endobronchial ultrasound guided transbronchial, either lung biopsy or lymph node aspiration. We had a publication on that in which we were able to have 30% patients who were confirmed to have either sarcoid or TB based on that. That is something that should be looked at. Of course, would not be done by you, but has to be requested by you so that your interventional pulmonologist can do it and help you out. Just another case. This is a 35-year-old male who presented with gradual painless decrease in vision both eyes for the past 2 months. 618, had a family history in that his father mysteriously had died of some illness in his 30s. She gave history of multiple episodes of dizziness and fatigue, had erectile dysfunction, bladder issues. When he came to us, he was on the wheelchair at sometimes, had multiple neurological issues with thickened sural nerves, and this is what he had on clinical exam. That's the slit examination of his cornea. You can see that those and this was present bilaterally, those point-like pinhead shaped regular millet seed, if I can use that term, deposits on the cornea. That is in the retrolental space, typical glass wool-like opacities, and those are the fundus montages of both the eyes. Cotton wool spot, microaneurysms, doesn't tell you much. The media is pretty good. There's not too much of vitreous inflammation, except if you don't look in the retrolental space. So had a retinal microangiopathy bilaterally. So what we did was, we actually, since he had enlarged sural nerves, he was taken up for a sural nerve biopsy on our request by the surgeon colleagues. And this is the H&E stain on the left. It shows you the amorphous extracellular material, and the confirmatory Congo red highlighted by the green arrow, which confirmed presence of amyloid, and that was familial, hence his father had it. And this patient, because he came terminally, was ordered some systemic immunosuppression with hospice care. So this is the role of specific targeted systemic biopsy, which you might not be doing, but you would be requesting. Coming to a conjunctival biopsy, and this is again one case, a 64-year-old female who was diagnosed case of stage 0 CLL, which basically is that it's incidentally detected, but you can have blood counts as much as 1 lakh. But since you have no other organ involvement, they just watch you and don't treat you. So she was not being treated, and had some non-resolving redness, treated with oral topical steroid elsewhere, was referred to us. That's what she had. The anterior segment was fine. That's what she had, like a localized patch there. The ultrasound, showed a epibulbar extension posteriorly. That is the upper temporal scan, and you can see that the eye was quiet, but there was an epibulbar hypoechoic, extension there. And so this is what we did. We essentially, this is easy for anyone to do. That's the area which is fleshy, bulbous. So this is under peribulbar block. But to try and minimize bleeding and to have a cleaner plane of dissection, I did inject some, 1 into 10,000 ADR with lignocaine, which I'm doing right there, as you can see, in different areas. Just as we would do akin to a conjunctival graft for a pterygium surgery, and then you would just take your scissors, but to have a full thickness, conjunctival and tenons, you would want to do that biopsy, get this off, and after you cut that piece off, That's what you get. This patient eventually, and then you want to suture this off. That's not difficult to do. But what this patient actually had was that the histopathology showed presence of CD56 and CD3 positive lymphocytes in the substantia propria, which matched exactly with the peripheral blood immunohistochemistry and flow cytometry reports. Hence, she had epibulbar involvement. So she got bumped up from a stage 0 to a stage 3 CLL and was started on serum chemotherapy and was eventually found to have that and that. So targeted extraocular chemotherapy, biopsy, which, helped with that. Aqueous biopsy is an AC tap. You can just take your taps and do. So this patient had a, granuloma, as I was shown. And just to confirm, an AC tap was taken, had some KPs and inflammation in the anterior chamber as well, and that came out to be positive for IS6110 and RPOB genes, and hence confirmed TB, pan uveitis with a choroidal granuloma, and this patient did rather well, and that's what that is. Quickly come to vitreous and subretinal biopsy. Simmers covered some of that. I'm going to limit myself to jump vitreous and limit myself to subretinal and beyond. This is some of the data on diagnostic. Simmer also covered a couple of these. These are some of our articles on this, and if anyone's interested, they can do their reading. This is just endogenous end off. I'm just going to a video which was a patient had. So I'm actually going to skip this because Simmer talked about this. I'm going to just go on to subretinal biopsy. Simmer, how much? What's the exact time? I can't see the clock on my.
It's 12:10, sir. We have 15 minutes more.
We have 15 minutes more. Great. So I'll just take 5 more minutes and then I'll end. So this is a 62-year-old male who presented with bilateral gradual painless vision, very low acuity, had some vitreous cells, had these occluded veins, and had those yellow whitish deposits. Also had a cardiac history. That's the left eye, much more advanced features. Again, had some vitreous cells. A clinical diagnosis. That's what the angiogram showed, and the blown up picture shows you a typical leopard skin appearance on the angio, which is also seen much more in the left eye, which was the worst eye as far as the affliction of the disease was concerned. And this patient was the clinical diagnosis of a lymphoma, was taken up for vitreous biopsy and subretinal biopsy of the lymphoma. So that's what we had. That's what the patient had. This is what we did, right? Under air. So the biopsy began under air infusion to get a undiluted vitreous sample. After that, we switched back to fluid, made an incision in the subretinal space with the cautery, and using passive, you can see that soft tip, using passive extrusion, just get those non-adherent lymphoma cells. We were able to get a big chunk of them by creating an opening. And then, as we would routinely do in RD surgery, do fluid air exchange, do laser, and we left this patient on SF6 gas. And this is what the patient had: CD20 positive, CD3 negative, diffuse large B-cell lymphoma. And this is sometime later. This patient eventually turned out and did pretty well. This is about 1 year later. This is a long time back patient. So, that's what that's how you can do a subretinal biopsy. This is another example of a patient, who had vitreous haze. Preoperative, we could see some lesions, but the vitreous haze precluded any kind of confident or clear fundus exam. Again, the biopsy was begun under diluted air infusion, as you can see. Undiluted biopsy was taken with the cut rate lowered to 800 cuts per minute and a manual aspiration being done. You can see air being infused and us cutting the vitreous. You can get up to a 1.5, maybe 2 ml biopsy vitreous sample, and then you switch back to fluid, and then you can clear up whatever you want to do. After you clear the vitreous, that's what you had. You have some of these deposits inferiorly, and that's the lesion which was there, which was not visible preoperatively, temporal to the fovea. So for the subretinal biopsy, that's what we did. Just made a routine, retinotomy with your endocautery tip, using the passive 25 gauge soft tip. Actually entered, we entered with that, and we were able to get out some of those, subretinal yellowish, what we thought were lymphoma cells. And this is passive, just attached to a 2 cc syringe. So just passively aspirating. And then we finished after we did with just doing laser, and I left this patient at, SF6. What this patient actually had was, I'm actually going to skip that video. That's going to be something. So the vitreous fluid showed nothing. Now, why do subretinal biopsy? There's hardly scanty cells. The subretinal aspirate, you can see a lot of cells. The morphology is better, and they typically show you high nucleocytoplasmic ratio, large amount of nucleoli, and CD20 positive. So just a vitreous biopsy in this patient would have been negative. However, subretinal biopsy saved the day. We're just going to end with one video. I'm not going to show. I had two more quickly just to show choreo-retinal biopsy and the limited indication where that might be needed. This is thanks to, this is because of courtesy Dr. Raman. This was actually taken from me. So the known case of toxoplasma was being treated, did fairly well. However, a week later had extremely poor vision and got down. The vision went down to hand motions because he had a bleed. So the regular biopsy was done, and you can see how thick the hyaloid is, as you will see right now. So that is not the retina. That is the thick, organized sheet of posterior hyaloid, which is just fibrosed over like a frozen lake. And the retina and the blood is, all of that is below it, as you'll see. So after clearing, you can see the retinal blood vessels, and you will be able to see those lesions clearly in a bit. That's what. So all of those are the retinitis lesions. With some vasculitis in the periphery and multifocal retinitis lesions. This patient had received an Ozurdex injection elsewhere and was referred to us, hence the multifocality. We wanted to take a choreo-rectal biopsy at this point in time because we want to know what's happening. Mixed infections are common, and although this patient responded somewhat to anti-toxotherapy, he had this precipitous loss in vision which was atypical for someone to have that amount of bleed. So a safe site was chosen superiorly, akin to what you would do to exteriorize a large foreign body. A separate sclerotomy was made with the MVR, and you had your old school scissors that you would use in maybe the 20 gauge era. And they were used to actually delimit and cut out a portion of the retina and a full thickness of the choroid involving healthy and the diseased retina after laser demarcating it. Yes, there was some bleeding, but that can be controlled by jacking the IOP up. You can see at the top left corner of the screen. And after much manipulation, the piece was actually brought out, as can be seen there. There was another piece which was subsequently brought out, and this was sent to the histopathologist in formalin. And the patient was that's what was done. And after a good laser, we closed the patient on oil. So this is just a how a choreo-rectal biopsy works. You can have other things in which your choreo-rectal biopsy might be needed. A diagnostic enucleation, I'm just going to skip that for want of time. A diagnostic enucleation might be needed in atypical cases of sympathetic ophthalmia, like this one-eyed lady, in which it looked nothing like sympathetic ophthalmia. The angio didn't look like it. We were suspecting a masquerade or AN. However, the blind eye was, enucleated, and this showed a rare atypical aggressive form of sympathetic ophthalmia, which is sympathetic retinitis, in which the inflammatory response tends to be directed towards the retina and not the choroid, and hence the choroid doesn't get thickened. The patient doesn't present with exudative RDs and KPs, but instead presents with massive outer retinal loss and rapid onset of fibrosis. However, we were able to manage this patient with, because of timely diagnosis and more than aggressive immunosuppressive therapy than you would give in a conventional sympathetic ophthalmia patient. We were able to manage this patient with IVMP, rituximab, and azathioprine, and this patient continues to do well. So with that, I'd like to actually draw a close. I think we're just bordering at the at the end of time, and I'm going to stop sharing.